Welcome to AETCM, the emergency medicine channel. As part of ABG analysis, today we are discussing respiratory acidosis, one of the very common conditions in emergency room. Respiratory acidosis means whenever there is respiratory distress, you can see that initially oxygen levels will come down. That is called as hypoxemia. We can call it as type 1 respiratory failure. Afterwards, if it is a chronic process or if it is a prolonged breathlessness, you can see that carbon dioxide will accumulate in our body. That is called as carbon dioxide retention. If there is hypoxemia and carbon dioxide retention, then we can call it as type 2 respiratory failure. When the carbon dioxide is retained in our body, you can see the formula in the last line. If the carbon dioxide is retained in our body, the production of carbonic acid will increase. This is called as respiratory acidosis. Here the carbonic acid increases, patient will develop low pH. pH will reduce. That is called as respiratory acidosis. To compensate that, the kidney also will try. That we will see afterwards. That is called as compensatory mechanism by kidney. So normally when there is breathlessness, initially there will be, if there is only tachypnea, oxygen levels can increase. Oxygen levels can decrease. That is type 1 respiratory failure. Then you get type 2 respiratory failure. Then carbon dioxide level increases and you can get acidosis. This is called as respiratory acidosis. Afterwards, kidney will try to compensate. That is called as compensatory phase. All these things we will see. Now, type 1 respiratory failure, we have already seen that low PaO2. Very common condition is acute asthma. And other conditions like acute pneumothorax, acute pneumonia, acute pulmonary embolism, ARDS, pulmonary edema. All these conditions, you can see initially PaO2 will be reduced significantly. And PaCO2 will be normal because carbon dioxide retention has not occurred. So PaCO2 is normal. At the end of 1 or 2 days, slowly the carbon dioxide levels may start increasing. That we will see afterwards. pH will be always normal. Bicarbonate also normal. Now chronic process, again the same conditions slightly become old. That means 1 or 2 days, after 1 or 2 days, this clinical profile will be almost similar. But after sometimes we will see what happens to this type of respiratory failure. Initially acute and chronic process almost will be same. But after sometimes you can see patient slowly develops carbon dioxide build-up, especially conditions like chronic asthma. That means asthma can present as acutely, in 1 or 2 days it can subside in some patients. Some patients it can even persist for 5-6 days. In that condition you can see slowly carbon dioxide level builds up. Then it will become type 2 respiratory failure. So chronic process is only for theoretical purpose. Type 1 respiratory failure is always an acute problem. And it is always a hypoxemic condition. It never produces hypercarbia. So all the acute conditions given in this chart is practically correct, but chronic conditions are not practically very correct because some of these patients can go to type 2 respiratory failure. So this chronic condition will come in between acute type 1 failure and type 2 failure. We will see what is type 2 failure. Type 2 failure, again, it is one of the most important condition what we get in emergency room. That is COPD is the most important condition. Central sleep apnea is very, very important. Then other conditions you can see here. That is acute tracheal obstruction, massive pneumothorax, massive hemothorax, drugs, brainstem stroke, Guillain-Barré syndrome. So here the chronic conditions are very important, that produces low PaO2 and elevated PaCO2. Whereas in acute condition the changes are not like chronic conditions. They are similar to type 1 failure, but some patients go to type 2 failure. Whatever it is, one of the most common condition in emergency room who have type 2 respiratory failure is COPD, ILD, central sleep apnea syndrome, prolonged ARDS, chest wall deformities. All these conditions can present type 2 respiratory failure. Here what happens is PaO2 is reduced, PaCO2 is increased, that increases carbonic acid, pH reduces, then compensation occurs so that pH may come back to near normal, and to compensate this acidosis, bicarbonate levels will be increased. That is done by kidney. We will see that. So you can remember the Anderson-Hasselbalch's equation, but normally we don't calculate all these things. It will be given in a point of care ABG machine. So you can see here carbon dioxide plus water, carbonic acid. On kidney side, hydrogen ion plus bicarbonate. So removal or adding up of hydrogen ion will make the alkali side to acid side. So removal or addition of carbon dioxide to the buffer system may lead to acidosis or alkalosis on the lung side. Whatever it is, kidney and lung will try to keep the pH in between 7.35 and 7.45. Now respiratory acidosis means the basic problem here is carbon dioxide retention. Type 1 respiratory failure, you have hypoxemia. Type 2 respiratory failure, you have increased carbon dioxide. Carbon dioxide retention occurs. The buffering system, because of this carbon dioxide, carbonic acid is produced more and pH will reduce. Bicarbonate initially will be normal, but after some times it slowly increases as a part of compensation. So that is respiratory acidosis with compensation. So this chart will explain you what is a respiratory acidosis and how it is compensated. For example, a patient who is having COPD, he will have permanently hypoxemia and hypercarbia. When there is an exacerbation, PaCO2 increases to a very high level, pH reduces to respiratory acidosis. Then since it is a chronic process, already bicarbonate level might have increased and further it may increase during acute episodes. So that level also will increase. Then the pH may come back to near normal. It will never cross to the opposite side. That means normally 7.35 to 7.45. It will be towards 7.35 to 7.3. It will never cross to 7.3132, towards the opposite side. That means more than 4 to 4.5 it will never come. It will be always towards less than 4, 3.5 to 4. Now we will see what are the causes. We have already seen the causes in the previous charts. You can remember these causes as COPDs. So that easy to remember. A cardiac arrest patient will have type 2 respiratory failure because they have hypoxemia and buildup of carbon dioxide. Obtundation like CNS depression due to drugs, encephalitis, stroke. Pulmonary diseases like COPD, these are the most important conditions. COPD, sleep apnea, pneumonia, ILD, all these things are very important. Drugs, sedatives, opiates, anesthesia patients. Anesthesia normally they don't go to respiratory acidosis because we are taking care of the patient, their saturation, respiration, everything is taken care by the treating physician or anesthetist. So they never go to acidosis, but if the patient is unattended on a ventilator, then the patient can go to acidosis. Electrolyte imbalance, hypokalemic muscle paralysis, that is very important. Hypokalemia as such will produce metabolic alkalosis, but hypokalemia induced respiratory muscle weakness will produce type 2 respiratory failure. Skeletal muscle weakness and neuromuscular weakness like GBS or any types of polio, all these things can also produce muscle weakness, diaphragm weakness, all these things patient can develop type 2 respiratory failure. So you can remember with a mnemonic COPDs. Clinical feature mainly hypoxemia and hypercapnia. These are the two important things. Hypoxemia will produce significant confusion. Hypercarbia will produce headache, flapping tremors and all. And patient also can have dyspnea, myoclonal jerk, flapping tremors, deep tendon reflex are blunted, increased intracranial tension can be there that produces papilledema. It is due to hypercarbia, and ultimately patient may go to carbon dioxide narcosis and coma. So if you are taking an ABG value, you can see that pH is primarily reduced, PaCO2 is increased. To compensate that, bicarbonate also will be increased. So initially when the patient comes, you can see that pH is reduced, PaCO2 is highly increased, bicarbonate also increased. If you treat the patient, carbon dioxide will come down and bicarbonate also will come down. But if you don't treat the patient, then bicarbonate levels will increase and pH will come back to near normal. You can see here the normally 7.35 to 7.45. So it will be towards 7.35 or less than 7.35, and it will never go to opposite side. If compensation means it is always in the limits, that we should understand. So the compensation will be in limit, that means 7.35 to 7.45 only, that to somewhere around 7.4 or below. It will never go to opposite side, it will never go to alkalotic side. If the pH is going towards alkalotic side, suppose the patient is having respiratory acidosis and pH is 7.45 or above, or 7.4 or above itself, you have to think there is another alkalotic metabolic problem. Sorry, there is an alkalotic acid base problem. So that is very important. The compensation means it is always in the limits. It cannot go to the opposite side. That is very important. So we can calculate the compensation with a formula like chronic respiratory acidosis, PaCO2 minus 40 by 10 for acute by 3 for chronic plus 24 will give you exact compensation. Why we need to calculate is, suppose there is another problem that, like you have seen that there is increased PaCO2 reduces pH and bicarbonate increases, and we calculate bicarbonate by this formula. If the bicarbonate levels are more than the calculated value, then you have to think that there is an additional problem, there is additional metabolic alkalosis. That is very, very important. So you can see here pH is reduced, PaCO2 is the primary problem that increases because of respiratory disorder. Then carbonic acid increases, pH reduces. To compensate that, kidney will try to increase the bicarbonate. You can easily think in this way also. Previously we have told that there is a formula. Here there is another easy formula. It is not formula, you can just compare here. For acute respiratory acidosis, for every 10 rise in PaCO2, you can see there is a elevation of plus 1 in kidneys, that is bicarbonate levels slightly increases to plus 1. That you can see 1 millimeter of mercury bicarbonate increases 0.1 milliequivalents of bicarbonate. PaCO2 increases by 1 millimeter of mercury, bicarbonate increases by 0.1 milliequivalents. So 10:1. But chronic it is slightly higher, 10:4 or 5. That is very important. So every 10 PaCO2 millimeter of mercury increase, you can see 4 milliequivalents per liter bicarbonate also increases. That is done by kidneys. So that is a compensation. This is another easiest method, but suppose the elevation is in 12 or 13, it will be very difficult to calculate, but somebody who are very good in mathematics, they can even use this method. It will be very easy to understand. If you calculate very fast, you can calculate this method also. Other method is a proper calculation. Here it's a easy way of calculating the compensation. Now once we understand the patient is having acidosis, we have to always see the clinical picture. Clinical picture means whenever there is carbon dioxide retention, you can see the peripheries are warm, patient is having altered behavior, patient is having confusion, and on examination you can see flapping tremors. Flapping tremor is seen in almost all types of encephalopathy, not only respiratory acidosis and respiratory carbon dioxide narcosis or hypoxic encephalopathy. Here it is due to hypoxic encephalopathy, but in hepatic encephalopathy, uremic encephalopathy, toxic encephalopathy, all encephalopathies you can see this phenomenon. This is called as asterisk sign or flapping tremors. Now chest x-rays are very important. You can see here the x-rays. You can see two different types of x-ray. One x-ray shows an increased lung parenchyma and it is black in color. That is because of air trapped inside the lungs. This is the classical picture you see in COPD. A small tubular heart, pushed down diaphragm, wide rib spaces, black color in the lung. You can compare the color of the lung with the external outer media. That is also black. Inside lung also black. That means both contains same type of air, the same amount of air. The air is trapped inside the lungs. Whereas you can see the second X-ray, the color of the lung is comparing with the outside area is not that deep. That means air is not trapped, but bilateral extensive lesions are there. These type of lesions can be seen in various lung pathologies like pneumonia, tuberculosis, ARDS. So many conditions you can get. Depending on the lesion, sometimes malignancy, so many conditions you can get. Depending on the pathology, patient can have hypoxemia, hypercarbia, low pH, respiratory acidosis, then compensation, bicarbonate levels can increase. All these things can happen. So pneumonia, if it is initially it produces only hypoxemia, then later it produces hypercarbia also. Now, once we understand the patient is having respiratory acidosis, we know that one of the most common condition we get respiratory acidosis in emergency room is acute exacerbation of some chronic diseases like COPD, ILD, bronchiectasis, cystic fibrosis, whatever it is, any chronic lung disease. One of the most important thing we always miss is obstructive sleep apnea syndrome. Many patients are falsely branded as COPD. You can take their history in detail. You can see thick neck and very obese patient branded as COPD, but most of the time they have obstructive sleep apnea syndrome. They also have type 2 respiratory failure and chronic compensation. Whatever it is, oxygen is the most important therapy initially. So you keep the patient in propped up position. Most of the breathlessness we keep the patient in propped up position. Then give oxygen. Oxygen can be given in various methods: nasal cannulas, injury mask, or facial mask, BiPAP ventilation. Whatever way we give oxygen, that will benefit the patient initially. But remember, in type 2 respiratory failure who is having chronic carbon dioxide retention, if we give very high flow oxygen continuously, then there is a chance of carbon dioxide washout from this patient. We should know that these high carbon dioxide levels are the respiratory drive for these patients. If you try to wash out the carbon dioxide, slowly patient may go to respiratory arrest. So we should avoid that. And in COPD patients or any chronic lung illness, we should maintain a target oxygen level somewhere around 85 to 95 in between, not more than 95, not more than 90 itself is dangerous. So very high oxygenation levels are dangerous in COPD patients. So initially give oxygen, try to make the patient better, then try to reduce the oxygen so that the saturation may be kept just above 84 or 85 to 90. That's more than enough. So that is very important. But whereas in other conditions like a clinically acute condition like a pneumonia, after 2-3 days if the patient develops type 2 respiratory failure and compensation, you can give oxygen or whatever treatment. You can improve the oxygenation above 95% because it's only an acute problem. He never had a permanent hypercarbia levels in blood. So try to improve the oxygenation like a normal person. Whereas in COPD and other chronic respiratory illness, where there is a chronic compensation and chronic hypercarbia, Never try to improve the oxygenation to a normal patient's level. Then bronchodilators are very, very important because COPD, asthma or any other condition, bronchodilators will help you to improve the oxygenation in the patient. So salbutamol with ipratropium bromide is an ideal choice. Salbutamol dilates the larger airway, ipratropium dilates the smaller airway, and ipratropium is the drug of choice in COPD. COPD is a small airway disease. BiPAP ventilation is very, very important because any breathlessness in emergency room, whether it is asthma, COPD, cardiac failure, whatever may be the breathlessness, BiPAP will be a very, very good choice. BiPAP or CPAP, it is called as NIV, non-invasive ventilation. Only problem is if the patient is having a pneumothorax or reduced GCS or hypotension, better to avoid NIV because it itself can produce increase in pneumothorax, increase in hypotension, or lot of issues in patients who is having loss of consciousness or low GCS. If the patient is not improving with the routine treatment, some patients may require mechanical ventilation. In COPD and all, COPD or any chronic illness, chronic respiratory illness, it is very easy to put the patient on mechanical ventilation so that patient improves very fast. The problem is weaning difficulty. We know that patient is chronically adapted to a system that the patient is having hypoxemia and hypercarbia. They are compensated for that. For many years they are compensated for that. Due to acute breathlessness, we may put the patient on ventilator, mechanical ventilator, and try to maintain the oxygenation and carbon dioxide levels like a normal person. But then it will be very difficult for patient to wean from that ventilator during recovery period. So delayed weaning is very, very important in patients who is having COPD or other chronic illness. So try to avoid mechanical ventilation. If no other choice, then we have to ventilate the patient. Other important things are in chronic respiratory acidosis. We have to always try to correct the potassium levels because these patients require high potassium. They are using their respiratory muscles continuously, and whatever drugs we are using like salbutamol, they also reduces the potassium level by shifting. So potassium has to be maintained in a normal range because potassium is very much important for muscle activities like diaphragm or skeletal muscles which helps in breathing. Then magnesium is very, very important because magnesium always try to dilate the bronchus, so that has to be given. Magnesium and potassium together we have to correct. Then next one is high protein diet and low carbohydrate diet. Diet has got very, very important role in COPD patients. Like most of these patients require, again like potassium, continuous muscle activity is required. So we have to give a high protein diet, and we don't want to give high carbohydrate diet because the end product of carbohydrate metabolism is carbon dioxide. We know that we have learned in physiology, and product of carbohydrate is carbon dioxide. So we try to avoid that. We are not restricting carbohydrate, but reduce the quantity of carbohydrate, increase the quantity of protein, increase the quantity of potassium if there is no other contraindication. These things are very, very important. Then once we are discharging the patient, we have to train the patient to use metered dose inhalers. Some patients may require spacers also. So spacer with metered dose inhalers are very important. They require chest physiotherapy and breathing exercises. All these things are very important to improve the lung capacity of the patient. So incendiary spirometry is one tool which can be used to improve the lung capacity of the patient. Then vaccination is also very important. All patients who is having chronic lung disease require H influenza, pneumococcal and H1N1, now COVID vaccine. All these things are very important to prevent further episodes. So we have discussed about one of the important problem in acid-base disorder, that is respiratory acidosis. We have type 1 respiratory failure, we have type 2 respiratory failure, 3 and 4 also there that we have not discussed here. Type 1 respiratory failure, hypoxemia. Type 2 respiratory failure, hypercarbia with hypoxemia. and hypercarbia will produce increased carbonic acid that produces low pH. So the patient develops respiratory acidosis. To compensate that, kidney will try to improve the bicarbonate or increase the bicarbonate levels. So the compensation will occur. So chronic compensation occurs in chronic lung disease. So if you are seeing a COPD patient, typically he will have slightly higher carbon dioxide levels, slightly acidotic side of pH. It is not always acidotic, it is towards the acidotic side. That means it may be somewhere near to 7.35 plus or minus 1 or 2. So that will be acidotic side. That is because of the compensation already occurred. That means bicarbonate levels are already high. But if the patient develops an acute problem, it will go to near acid side. So it will be really lower than 7.35, 7.3 or 7.2 or 7.1. That side, you can see the bicarbonate levels are slowly building up. That means compensation is occurring. But in this patient, if you are giving soda bicarb, we can see that acidotic part will be corrected, pH will be coming back to normal. But that is not a good choice. Many physicians unknowingly give soda bicarb in many acidosis. So they are only the soda bicarb will only cover up the issue. It will not correct the issue. To correct the issue, here oxygenation should be improved, not the bicarbonate. So never try to give bicarbonate in this type of conditions unless until it is emergency. It is most of the conditions we don't prefer bicarbonate, whether it is metabolic acidosis or respiratory acidosis. We have to correct the problem here. We have to improve the oxygenation. We have to reduce the carbon dioxide levels so that the acidosis also will be corrected. Thank you.